Welcome back to OMFS Essentials. Having covered patient evaluation, we now move to the surgical procedure for removing an impacted mandibular third molar. The procedure is a systematic sequence of steps, creating access, removing bone, sectioning the tooth, preparing the socket, and closing the wound. Today, in Part 1, we focus on establishing safe access and managing hard tissue through bone removal and odontectomy. Incision and flap design. The flap must be designed to follow all the basic principles. The base must be wider than the apex, and the incision should be large enough to allow passive, direct access. Recommended incisions, wards. The most common designs are the three-cornered flap variations, such as the Ward 1 or Ward 2 incisions. Horizontal component extends anteriorly in the gingival crevice from the retromolar area up to the distal aspect of the second molar. Vertical component, relieving incision, this is placed along and slightly lateral to the anterior border of the ramus. Its length is determined by the required access, typically about 1 centimeter. Critical flap precautions. Lingual safety. The vertical incision must be kept lateral to the anterior ramus border. Placing it lingually risks damage to the lingual nerve and lingual nutrient vessels. Facial artery protection. To prevent the knife from slipping and injuring the facial artery, a beginner should direct the knife from the depth of the vestibule up to the gingival margin, not the other way around. Flap thickness. The incision must be full thickness or mucoperiosteal and made in a single continuous stroke. Flap reflection. Buccal flap. Reflected sharply with a periosteal elevator in the subperiosteal plane. This flap is protected during bone removal using an Austin's retractor. Lingual flap, mandatory reflection. While many clinicians avoid it due to fear of lingual nerve damage, lingual flap reflection is safe and necessary for 2 reasons. 1. The lingual nerve lies supraperiosteally. Reflecting the flap in the subperiosteal plane tight to the bone safely reflects the nerve with the flap. 2. It allows safe removal of the distal lingual lock of bone that often prevents tooth elevation. Bone removal, osteotomy. The goal is judicious bone preservation. The tooth is sacrificed, but the bone must be preserved. Bone cutting methods. Rotary instruments, preferred. Use sharp stainless steel or carbide burrs at an ideal speed of 18,000 to 20,000 RPM with adequate torque. Contraindications: air rotors are contraindicated due to the risk of surgical emphysema, as air is forced into open tissue planes. Diamond burrs are not recommended for bulk bone cutting due to excessive heat generation. Irrigation. Copious irrigation with cold, normal saline is mandatory to dissipate heat and prevent bone necrosis. Chisel and mallet. This method is less preferred as it can cause patient anxiety and risks splitting the bone. If used, 2 vertical stop cuts must be made first to prevent the split from traveling along the bone grains. Osteotomy technique. Distobuccal gutter. Bone is typically removed distobuccally to expose the crown up to the cemento-enamel junction. This creates the distobuccal gutter and facilitates elevator placement. Distolingual lock. The bone on the distolingual aspect must also be removed to eliminate the distolingual lock that often prevents luxation. Direct vision. Bone should only be removed under direct vision after carefully observing where the tooth is locked. Blind bone removal leads to unnecessary and excessive bone loss, weakening the mandible at the external oblique ridge. Odontectomy. Tooth splitting. Odontectomy is the planned sectioning of the tooth into pieces to allow its removal without excessive bone removal. The dictum is, tooth belongs to the surgeon, bone belongs to the patient. Indications for odontectomy. Crown size. Large bulbous crowns. Depth and angulation. deep horizontal or mesioangular impactions. Root form: distoangular impactions, hypercementosed, divergent, or delacerated roots. Risk mitigation: when roots are in close proximity to the inferior alveolar nerve. Technique: the tooth is cut approximately 2/3 of its thickness using a burr, and the remaining portion is fractured with an elevator or chisel. Removing the crown first creates space for the delivery of the roots, preventing them from rotating against and damaging the inferior alveolar nerve. Criteria for leaving a root fragment: leaving a root fragment is not necessarily negligence, but rather a deliberate decision known as standard care. If it is 1. The root is free of periapical pathology. 2. Removal attempts pose a risk of damage to vital structures, such as the IAN. 3. The fragment is minor, less than 5 millimeters, and inaccessible. The patient must be informed if a root tip is left. These fragments are usually harmless and may resorb or become superficial over time. Summary: successful third molar removal requires systematic adherence to principles designed to protect soft tissue and conserve bone. This involves using a large, full-thickness flap, warts, with the vertical component lateral to the ramus, employing controlled rotary instruments with copious irrigation to avoid thermal necrosis, performing odontectomy to allow piecemeal removal, thereby preserving the structural integrity of the mandible. In our next episode, we will detail the final stages of the procedure: meticulous wound debridement, proper suturing technique, and crucial post-operative care. You've been listening to OMFS Essentials. As always, keep mastering the essentials.